morning.
I'm very pleased to facilitate this session on this very important theme, that is the healthcare financing towards reaching health equity in Africa. It's my great honor to introduce the distinguished panelist, or Dr. Jumemi. Dr. Jumemi is senior health economist specializing in health financing, public management, universal healthcare. That's great for our panel, which has to do with financing. He is also monitoring and evaluating public health program. He was a PhD in public health, specialization in health economics from the School of Public Health and Family Medicine, University of Cape Town. So he will be bringing to us probably the experience of South Africa. He's also a senior lecturer, a researcher in public health evaluation, health economics, health policy, and health system, healthcare financing and management in the Department of Public Health, Faculty of Medicine and Biomedical Science in Yaoundé, or what was called before was called the CUS. Next will be Joseph Tankwa, my brother Tankwa. You are a health economist, and we have worked with many local and international organizations. So we will really want to tap into your international organization on this important issue. You also have more than 15 years in both systems of education, English and French, and you also have a really penetrating mind that allows you not only to grasp the basics of economic theory applied to health, but also to formulate highly original and persuasive interpretive arguments. What I see here, which is very important and interesting for me, is that you have a sound knowledge of strategic health purchasing arrangement, and you are currently writing articles, blog and policy briefs on the topic. I'll just stop here, because if I was to release all your background, we will not get there. Thank you very much for being with us.
Thank you for having me on board. Thank you for having me on board, Professor. I'm honored and humbled.
And last and not the least is my brother from Nigeria, I suppose, Dr. Babandi, who is a public health physician. Finally, we have a physician with us with interest in health systems training and maternal and child health. You are a consultant in public health, and also you are a technical advisor to the Nigerian National Emergency Maternal and Child Health Intervention Center. And you're also a member of the Nigerian Institute of Management and the fellow of the West African College of Physicians and National Postgraduate Medical College of Nigeria. Thank you very much, Dr. Babandi, to being with us this morning.
Thank you very much, Prof. It's my pleasure to be with you.
Yeah. Before I start, I will just explain myself, saying, Utinam diwesim. Yes, Utinam diwesim. Latin will say Utinam diwesim. If only I was rich. And don't ask me what I would do if I was rich. If I was rich, you'll be surprised. I'll not be here this morning. I'll not be here to moderate this session, because I will just have money, and then I will be financing a health system. Then there will not be any problem. But I'm not rich. And that's the reason why we are here, to try and find a solution on this important issue of financing. So we will start, I'll allocate 3 minutes to each of you as kind of opening comment to give me your broad overview on the topic. So let me start in the same way I did the introduction of the panelists. So let me start with Dr. Jumemi. Tell me, please, tell the audience, not me, the audience, your broad overview on this important topic. Please, you have the floor.
Thank you, Professor. Good morning, everyone. Yes, when I received the invitation for this panel, I was very excited to really discuss the issue of healthcare financing to our equity in Africa. Yes, you might see that in terms of health economy, we are either trying to emphasize the efficiency and the equity. Sometimes both concepts don't work together. And sometimes they can work together because it might, in some context of financing, you might have to emphasize the efficiency and also the equity. The critical challenge in the African context is that there's a huge amount of mismanagement of financing, meaning that it might be important to really just reallocate the existing financing. Maybe in some contexts we even don't need additional funding, but if the existing funding is well managed, we might be addressed a number of health issues. But at the same time, you know that the out-of-pocket payment is weighted the co-payment, meaning that more of the healthcare financing are actually supported by family and household and individual. This is a challenge. You may even know that if you take in terms of percentage, those who are you take the economic country, meaning the poorest and the poor. There is a group who are really supporting the high financial building of addressing a number of health problems in the African context. That's why the equity aspect come in is very important. How can we now try to improve and sustain a kind of financing who might be able to address the issue of efficiency as far as we are concerned with accessibility and accessibility to quality of care, because no matter we are assessing healthcare, but is the healthcare a good quality? Is good quality? Who gets the good quality of care in the African context? Who pay? Who pay what? And who pay for what? And when we see that most of this has been really not well addressed in terms of equity, because actually maybe if we've found many tertiary hospital or even up to this regional hospital in some country or provincial hospital in some country, we find that the access to care at those levels is particularly costly for household or individual patient, and meaning that there's a good issue of care. But even it has a macroeconomic aspect of care. Even the allocation of healthcare financing budget or healthcare financing as a whole do not really follow the epidemiological profile. I mean that the money don't go to where we are having a substantial problem. Sometimes the financing or the money is where is allocated to where maybe the need is not so high. How can we then now try to put together, address the need of the community or population with some financial mechanism who will really address the equity issue? I mean, I think that the only way to do that is to move in the good way to the universal coverage or some kind of universal health insurance. This is why I can say as a beginning. But for now, it's a very big challenge in the African context where the level of poverty is high and where people don't have to pay a huge proportion of the amount to seek their health care. This is a particular challenge. Thank you. From there.
Thank you so much, Dr. Jumemi. Before I give the floor to Joseph, I will just say that I retain two important things from your intervention. That is, you raised this important issue of making the difference between efficiency and equity. And this is interesting that we start by making sure that, as you said it, efficiency doesn't work with equity. And you also brought something that makes me smile a bit, because I started by saying, Otinamdi was sim. If I was rich, I would not be here. I would not be here. But it would not be enough. That's what you bring me to think about. That if I was rich and I had all the money, even having all the money would not be enough, because also sharing this money is another issue. So we'll still be here. So please, I raise my case. If I was rich, Otinamdi was sim, we'll still be here to know how best to share this money among us. So I'll give the floor to Joseph, and Joseph Tangwa, please allocate you only three minutes. Yes, I think it's a lot to give us your overview on this important topic. Please, you have the floor.
Thank you, Professor, for giving me the floor. I would first of all like to say that I'm really honored and privileged to share the panel with Dr. Zachary Anjumemi, whose articles I've always used intensively in my own publications. I'm really privileged. I want to say, just to begin, he has already set the pace in most of the topics that he has touched. The topic about equity, about health financing, is a crucial topic. We usually say in French, l'argent, c'est le nerf de la guerre. I would like to say l'argent, c'est le nerf de la santé. And prior to COVID-19, we already knew that our health systems were really fragile. They were weak. And COVID-19 has instead come to fragilize the system further. We need to look into all the three main components of health financing, like you rightly said in the question, about mobilization of resources, about the pooling of the resources, and the purchasing. I would like to believe that in the next questions, we'll be able to go deeper into all the aspects, because in a nutshell, we know that we have a poor mobilization capacity. If I take the example only of my own country, Cameroon, there is a lot of leakages in the resources mobilization. There are many hospitals that could have been built had it been we collected the resources, all the resources that we could have collected. Because some studies have shown that more than 40 to 50% of the resources collected are embezzled. So there is this high level of corruption that reduces the amount of resources mobilized. Even at the level of the pooling of resources, we have a lot of problems. The pooling capacity actually in Cameroon, for example, does not even exceed 6% of the population. So there is a big challenge at that level. And even concerning purchasing, where I am more interested, it has been suggested and even recommended that we move from what we call passive purchasing to active purchasing, strategic purchasing. Like Dr. Njumeni said a while ago, there is a lot of allocative inefficiencies in our health systems, a lot of allocative inefficiencies. And even when you go deep into the countries, you will see differences at the level of region. There are regional differences. You start asking yourself, what is the rationale in the allocation of those resources? Is it that they're trying to compensate or to reward the populations according to their political leniencies? So we need to look into that. And I would like to finish by saying that when we talk of efficiency, this egalitarian approach that we used to use in efficiency and equity is kind of questioned now amongst researchers. And like, you need to strike a balance between the equity and the efficiency. The more you go towards equity, the less you are efficient. And the more you go towards efficiency, the less you get equity. So how do we strike a balance between those two extremes? Thank you, Professor.
Merci beaucoup, Joseph. Si je comprends bien, l'argent
L'argent, c'est le nerf de la
de la
santé.
guerre, c'est le nerf de la guerre, mais vous allez plus loin et vous dites que l'argent, c'est le nerf de la santé. Ça,
Ouais.
c'est très intéressant. Joseph brought in a new issue. Money is there. So I still would not now say sim because the issue is not about the availability of money. Money is there, but what we need is capacity for mobilizing that money. And also, if we could have a better management of this money, I would not say it, but that's what you meant. You mentioned the issue of poor management of our money, which is a bit broader that investment of funds. Yes, I just add this to not to point a finger on anyone, but we know that if money was there, if we're all rich, we still have issue of managing the existing fund. And finally, you came back again on this issue of making the difference between equity and the efficiency, which may not go in the same direction. They may be going into opposite direction. Thank you so much, Joseph, for bringing this new aspect of the issue. So I'm now going to give the floor to Dr. Babang D. We also want to tap into his, my brother and neighbor's experience from Nigeria. Please, you have the floor.
All right, thank you very much, Prof. Good morning. It's my pleasure to be in the midst of distinguished panelists. I would just want to start by saying to bring equity into for health, equity can only be achieved when everyone in every place is able to achieve his full potential to health and well-being. It therefore means that the unfair and unavoidable differences that we see across socio-economic groups, across geographical locations, across different gender and so on. So health equity forms the fundamental tenets of universal health coverage, and even towards achievement of sustainable development goals. And equity in health really is to a large extent determined by the social determinants and the medical determinants of health. It therefore goes to say that to achieve health equity goes really beyond what can only be done within the health sector. It requires concerted effort in social investment, in employment opportunities, in education opportunities, to take care of those social determinants of health, which to some large extent determine the need and the eventually equity in health. But well, here we are discussing healthcare financing as one of the pillars of the health systems, as how we can use the mechanisms of healthcare financing to tackle the issue of health equity in Africa. And I think it's particularly important in Africa if we look at the background of the weak health systems we have, the high burden of tuberculosis, malaria, HIV, and other infectious problems, and to add to it to the additional double burden of non-communicable diseases, and of course issues of conflict, violence, terrorism. So it goes a long way to say that health equity in Africa is something that cannot be, it cannot be overemphasized because of the demographic, because of the health backgrounds we have in this environment. So I'm coming to healthcare financing. The health resource mobilization towards achieving health for Africans is really suboptimal, as reports have shown that less than 4 countries in Africa have actually been able to meet up to the Abuja Declaration to meet up to 15% of their budgetary allocation to health. African countries have a limited or a constrained physical space due to low GDP. Therefore, the capacity to generate funds is also not optimal. There is also the issue of donor funding, which goes both ways. I mean, there is a lot of argument and a lot of discussion about the importance or otherwise of donor funding in Africa. But reports have shown that in some countries, up to 40% of their health expenditure comes from donor fund. So here, the point is the unpredictability, and also sometimes difficulty to harmonize those funds to achieve what it's meant to achieve. On the issue of also pooling of the health resources, again, in more than 23 countries in Africa, out-of-pocket expenditure is said to account for more than 40% of the health expenditure, which means majority of countries in Africa and the population are actually incurring some kind of catastrophic health expenditure. Likewise, there is a lot of inefficiency and a lot of inequality in even allocation of the meager health resources. There is a kind of inverse care where those who need the care, particularly if I give example with my country in Nigeria, those who need the care are actually getting far less than those who ordinarily do not need care. So the inverse care is really a problem. The impoverishing care, where people are made to pay huge amount of monies to assess basic healthcare. So I think that is unacceptable, and that is something that needs to be seen. That is something that the decisive action needs to be taken, particularly when it comes to allocation and efficiency of resources in Africa. Thank you. I think I would stop here.
Thank you so much. Thank you again, Zaharajin. Thank you for bringing this important additional issue. You really set the tone, and if you even anticipated what will be our second point of discussion. So from what I retain from your intervention is that the social and medical determinants of health should be really considered when talking about health equity. And we cannot emphasize the health equity cannot be emphasized much in Africa. And also you already anticipated on the next question, so I will not go back to it because we'll have to discuss about this Abuja Declaration of 2001. So now we've set the tone of our discussion. Yes, I would say the tone, but we have less time to go. Anyway, we'll try and do our best during the 30 minutes that are left. Now, I will ask one question, and this question, please, I will request all of you to give a view about it, because it's an important question regarding the issue of healthcare financing in Africa. So if we consider the main functions of health care financing, that is mobilizing resources, pooling of funds, purchasing health services, what do you think of the actual health care financing system in the majority of African countries? As again, I'll start then again with Dr. Jumemi. Please let me have your view on what you think about the actual healthcare financing system in the majority of African countries. You have the floor.
Thank you, Professor. The actual situation of healthcare financing in most African countries is very diverse. I think there's not an harmonized healthcare financing system across African countries. We found that some countries actually still moving and emphasizing the input-based financing, meaning that the healthcare financing is particularly based on government or state taxation and particularly on state taxation, as a main sources of the healthcare financing. All government are collecting tax and some duty from export to finance healthcare. This is challenging because sometimes we know that the level of tax taxation and even they need to make some trade-off between the health sector and other competitive sectors such as social sectors such as education, employment, and so on. Even with some non-social sectors like security and the security as well. This means that the challenge is that the sustainability of this funding, social funding, can be questioned because it's not always really well perceived. But there are few of the countries in Africa who are really moving from what my colleague there call strategic purchasing approaches for healthcare financing. You know that financing of healthcare have two aspects. We have financing of supply bias financing and demand side bias financing. Meaning that when I talk about supply side bias financing, meaning that the financing is mainly focusing on the provider side. This financing mechanism try to see, or policy, try to strengthen the capacity of different healthcare providers to have all the standardized equipment required to deliver quality healthcare. And sometimes when they did that, I suppose that there's an economic theory saying that when the supply is good, finally the demand will follow. If the supply is bad, finally some demand will just go away. That's why when we emphasize the supply side financing approaches, we think that all providers should be public provider, private for profit, or private confessional, non for profit, or even private community. They can, if they are strengthening, if the drugs are available at facility, if the staff, the quality of staff are available at facility, if all the equipment required to deliver quality care are available at facility, finally, the quality of care will be good, and then people will try to seek care at former facility. But this is not always the case. The other side is that, given the social context, I'm happy that one of my colleagues talked about social economy and social determinant of care. This is a particular good point. The demand side of healthcare financing tries to stimulate people even to seek care, having in mind that they will not have to pay any cash or other form of any form before getting the healthcare they need. They can satisfy their health demand, their health need, without having to pay any money at the point of the delivery, of service delivery. In this case, we have many strategies, many approaches have been experienced by a number of countries. We have voucher, we have experimental financing, we have even some countries try to move to universal coverage. There are many of them. You can come the case of Senegal, the case of Gabon here in South Africa, have the case of Rwanda, we have the case of South Africa. There are a number of countries, there are more of them. But the level, we have the case of Ghana as well. We have the way you read, as you try to assess how those countries try to implement this universal coverage. They are not using the same approaches to implement this universal health coverage. For instance, to address the equity issue, most of the countries try to put in place what they call the camp for the poor. There's one finance mechanism who's really take care of healthcare financing of poor people or low-income people within the country. What they made is that those people, the people qualified as poor or very poor, don't have to pay even to contribute into this pool, because people are contributing in terms of their contributive capacity, to afford the prepayment fee fees by discount. But This camp is really addressing the care, trying to facilitate the access to healthcare for the poor. Is largely financed by the state budget with domestic funding, and mainly in most of the country with external funding from different donors. What is the challenge there is the sustainability. And in number of cases, some countries like Togo try to, even here in Cameroon, of course, as well, in the number of countries, try to carry out some operational studies to identify the innovative sources of healthcare financing, particularly domestic sources for innovative financing of healthcare. You can see that in some countries, take the case of Gabon. The government used to introduce the taxation of communication company like MTN, mobile money, and so on, to generate more resources locally to finance partly the healthcare. But in some countries, the same mobilization will be done. But when the taxation department, that's the mobile money and audit kind of money transfer, this money was put in the common basket in the treasury. It was not actually sent or allocated exclusively to the health sector. This is another big challenge, because in some countries, they identify the same innovative source of financing, but when the money come in towards the tax collection and into the treasury, the money is used in different ways. The money is, the health sector is competitive.
My brother Jumemi,
Yes.
I know you have a lot to say about this, but I'm looking at the managing of our time, and we are left with less than 30 minutes. And you still have a lot to say about this important issue. So maybe the other panelists have also something to share. But what I retain, what you've said it, this is extremely important that we retain this. You raise the issue of supply side and the demand side, and you put more emphasis on the supply side, which has to do with equipment. And also for you, and I think I share this view, there's no harmonized healthcare financing system in Africa. Maybe we should work towards harmonizing this in Africa. Merci beaucoup. Et je vais passer la parole à notre ami Joseph Tankwa. Joseph Tankwa, you have...
Thank you, Professor. Would you like me to continue in English or in French?
It's up to you. It's
okay.
Up to you.
Yeah, I was so interested by what Dr. Jumemi was saying that I even forgot that I had to say something. I won't dwell on what he has already said, but I would like us to go again through those main core functions, because I talked of this resource mobilization. There is what we call at the United Nations level, the mobilization of the maximum available resources. It has the acronym of MAR. If there are students in the panel or in assistance, that is a domain where I would like them to really go into.
Please, will you repeat it again, please?
The mobilization of maximum available resources, MAR.
Okay.
How can a country mobilize to the best of its capacity the available resources? Because our health systems were greatly dependent on external sources of funding. But with the COVID-19, many external countries had to prioritize their own citizens. So there was a reduction of funds, external funds in many of the countries. You will be shocked to know, for example, that maternal health care in our country was financed up to the tune of 90% by external resources. Mm-hmm. So you can imagine the impact that COVID-19 had on maternal health care, because we carried out a study on maternal health care in the northern regions of our country, and we saw it was alarming. So we need to see how best we can mobilize domestic resources. And many experts have said that we should really look into the domain of mineral resources in mines, because it is not really well organized and we can have many resources from there. If I want to leave from there to the pooling of resources, we have a serious problem with our systems. I'm talking for Cameroon, but we have done some cross-country, multi-country studies that shows that our health systems are highly fragmented. There is this problem of fragmentation. You will have in a country like Cameroon, we made a study, we discovered that there were more than 30 health financing mechanisms, more than 30 schemes that were not aligned, that were vertical. And all the previous ministers of health have tried to the best of their capacities to harmonize these schemes, but they failed because they have different sources, different funders with their own policies. And you know that when there is fragmentation, it leads to so many problems in the system. Fragmentation will lead to high administrative costs, uncoordinated care and poor quality of care, and so on and so forth. So there must be a way to defragment our health system because it causes overlaps. Overlaps in the sense that you take a woman, for example, in, let's say, Marwa, in the east, far north region of Cameroon. She is in what they call the Sheikh Santé. The Sheikh Santé is what they call the health voucher program. The health voucher program is a supply side health financing scheme. The same health facility will have what they call the PBF, the performance-based financing, which is a demand side health financing. And both deal with maternal health care. So there's a kind of overlap. The health facility receives money for the same woman for Sheikh Santé, for the same woman for PBF. And there are other programs like that. So we have a highly fragmented health system, and it causes a lot of inefficiencies, and we have to look into it. Now, concerning purchasing, I'm still coming back on that strategic purchasing. We need to ask ourselves these three main questions when we do purchasing. Purchasing is not only about procurement. It's about asking yourself three strategic questions. What services are we to buy? Here we talk about the entitlement benefit package. Where are we going to buy those services? We talk about contracting procedures. And how are we going to pay the service providers? There we talk about the payment mechanisms. Are the payment mechanisms incentivizing the front workers enough for them to deliver quality care? Because this result-based financing approach that our countries are using, particularly Cameroon, are meant to move towards universal health coverage. So it's about seeing how we can leverage on what has been gained from all this performance or result-based financing approach to see how we can finally move towards our 2035 project of universal health coverage. Thank you, Professor.
Thank you so much, Joseph. What I retain from your contribution is this immobilization of the maximum available resources that you bring to the floor from the international organization, meaning that we should do all the best we can. It's not just an issue of mobilizing the resources, but we should mobilize the maximum resources, what the priest will call at the university, Catholic University, they will say la recherche de l'excellence. Also, you brought this into on the floor, that a big chunk of financing comes from outside. It doesn't mean that we don't have the resources internally. We should make every effort to mobilize what we already have internally. And this is where you brought something that I was expecting. I would not have been happy if we are not mentioning this, is on the issue of domestic resource mobilization. The African Capacity Building Foundation, ACBF, which is based in Harare and is a specialized agency of the African Union for capacity building in Africa, has written its third flagship report on domestic resource mobilization in Africa. Yes, it was not focused on health, but I'm very happy that you brought this issue on the floor. Domestic resource mobilization is really important for us. And finally, you brought the issue of purchasing not being only about procurement. It's here that you brought the where, when, and how it should be considered. Thank you so much for bringing this highlight on of this issue. So finally, I give you the floor, my brother from Nigeria, Dr. Babandi. Let us have your view on this issue. Please, you have the floor.
Thank you very much, Prof. A lot has been said already, and just to buttress, there probably wouldn't be a universal opinion or something representative of what is obtainable in African countries as regards to healthcare financing. But I think for the majority of the countries, again, the problem lies again on the pooling, on the resource mobilization. There is still a lot to be done as regards funding for healthcare. Evidence has shown that per capita spending on health has a direct correlation with the achievement of universal health coverage in many countries. But in Africa, some countries will report as low as $8 per capita as regards healthcare financing. Funding for health. While in some developed countries, we talk about per capita as much as $4,000 per capita. So there is really a lot. If you look at the percentage of also GDP funding for health, which is also an indicator that has shown to have direct correlation with the achievement of universal health coverage. A 5% GDP for funding for health has been suggested, which in many African countries, there is, it's really a far cry to what is actually obtainable. Someone has rightly mentioned the dwindling donor funding. Many African countries, Nigeria inclusive, are heavily dependent on donor financing. And with the coming of COVID, with so much economic recession, a lot of these donor fundings have started to shrink. And that leaves most of our programs to be vulnerable because they are not sustainable. The countries do not have the capacity to sustain those, sustain the funding of such programs. Even the capacity to raise funds in Africa. Yes, there is that potential, a lot of potential, but there is a reduced capacity for funds to be raised, not even only for health, because most of the economic activities are in informal sector, and that brings limited capacity to raise tax, both general tax revenues or earmarked taxes for health. So there is really a diminished, or there is really more needs to be done, significantly so as regards to funding for health in Africa. As regards to pooling of resources, again, it boils down to health insurance. I know many African countries have come up with some innovative mechanisms to cover the informal sector. But like in Nigeria, the health insurance coverage still lies around 5 to 8% of the country. And it's mostly on those employed in the formal sector. And the majority of people in Africa are either unemployed or they are employed in the informal sector. So there is really a huge gap as regards health insurance coverage. And in some instances, particularly in Nigeria, where efforts have been made to cover some of these lapses as regards the informal sector, most of those came up with unsustainable programs just to score some political points, particularly when it gets to periods of election. State governments begin to declare free health services, which are not obtainable, or or they are, but at a very, very compromised quality, just to be able to accommodate within the meager resources that are made that are available. And you could have those programs separately from the National Health Insurance Authority, a different program from a state, probably health insurance board, and even at the local government or at the world level, people are making independent efforts to provide healthcare to those not in the formal sector. But most
Dr.
of those,
Dr. Babandi,
yes.
if I don't stop you, Vanessa will blame me for not being able to manage properly my time,
Okay.
because I'm left with only 8 minutes, and we still have a lot to share. I'm not quite sure that in 1 hour was enough. Maybe that's where I will blame Vanessa, because she should have allocated us five hours to discuss this important issue. Sorry for this. And since we are left with only 7 minutes, I will take the opportunity to raise an important issue, this issue of the Abuja Declaration of 2001, which recommended that government should allocate 15% of the budget to the health sector. Please, just allocate. I will give you only 1 minute to share your view, your take on this issue. So I repeat my question. The Abuja Declaration of 2001 recommended that governors should allocate at least, I say at least, I don't know whether it's at least or was exactly 15% of the budget to the health sector. Let's go quickly have our view on this, because it's important for us. That's where governors should be, should account on how did they implement those decisions that they took abroad. Let me start again in the same order. So I'll give the floor first to Dr. Jumemi, and then the same order. Please, my brother Zachariah, you have the floor.
Thank you.
1 minute,
Thank you,
please.
Professor. Thank you, Professor. But I will quickly correct something where Joseph said pay-for-mobile financing is demand-side financing. No, pay-for-mobile financing is supply-side approach of financing, and voucher or shared santé is the demand side. This is just the question I want to make.
Okay, sorry.
Let's come back now to the issue of this Abuja. No country,
yes,
no country actually up to 2022 now, no country reached this level. The challenge is because we are really focused more our resource allocation is not based on allocative efficiency, and there are many competing needs within African context where sometimes the health sector is not the top priority. If the health sector was a top priority, normally the allocation of domestic funding or the national budget to healthcare will be attended this level. But it's a particular challenge because also the issue of public financial management. Public financial management. The issue of public financial management sometimes do not align with other financial mechanisms such as reservoir financing or even social insurance or other type of insurance, health insurance. That is another challenge we are facing because the procedure of our financial public management is mainly managed from the Ministry of Finance in different countries. That is what I can say about this issue. And then the health ministry are not have the power to influence the budget allocation too much. This is what I can say. Thank you.
Okay, Joseph.
Thank you, Dr. Njumemi, for rectifying what I said. It was really a mixed up. I said the opposite. Thanks a lot about the demand side and supply side. I kind of asked myself, how did they really get to that percentage of 15%? And when those head of state took that commitment, did they really mean it? Because when you look through the past years since that commitment, some countries instead reduce the percentage of fund that they allocate to health. When you take the case of Cameroon, because that's my country, it's even dropping. It started from 5% just for the Ministry of Health, has dropped to something like 4%. There's a positive, a negative trend in the evolution. And it's kind of the case for many other African countries. So I'm really asking myself, how did they get to that percentage, and did they really mean it when they took that commitment? But I would like to dwell on one aspect concerning that we actually skipped our mind. It's about these out-of-pocket payments. That is really a burden.
10 seconds. 10 seconds.
It's really a burden in our communities, and people are pushed into catastrophic expenditure and impoverishment. And we need to really see how we can take it off to that 15%. If not the 15%, at least try to see how each year we go towards that kind of asymptote. Thank you.
Thank you so much. Thank you so much. I will first give the floor to Dr. Babandi before I come back to comment your intervention, your contribution to this last question, which I think will be the last question. Please, Dr. Babangida, go.
Okay, thank you very, very much. I would say too that the Abuja declaration of 15% is quite ambitious, but it's good. It serves as an advocacy tool to get funding in the health sector, even though the basis of that 15% is not clear, and there is no explicit connection between the the percentage earmarked and the health system performance. So I think the 15% Abuja declaration is good. It's used as an advocacy tool to get more funding into the health sector, but it has its own reservation. I mean, there are so much reservations from it, and I think we should start looking at not how much is being budgeted for, but how optimally are those resources used, and has there been any difference in the health system based on what has been used. So I think it's better we begin to talk about improve timeliness on flow of health resources. We should try to reduce budget on the performance of budget, because even when the 15% is given, you could see budget performance of 40–50% in many countries. And there should be an increased efficiency and accountability as regards to resource mobilization and resource use for health. But we can still keep Abuja declaration and use it for advocacy to get more money into health. But we should start to ask questions beyond how much, but how well the money has been used and how much change we've been able to achieve with the money given. Thank you.
Okay, thank you. Before you started intervening on this issue of 15%, I was about to smile, asking myself, as you did it, Dr. Jumemi, how come the head of states come to this target of 15%? Now, with your contribution, Dr. Babandi, I understand that they are not to blame. It can be seen as an advocacy tool. That is, we put the bar high so that every year, as Dr. Jumemi said it, we should not be looking at the amount, but we should be looking at the trend. Is the trend increasing? Are we moving towards, even if it's not 15%, at least from year to year, are we increasing? And this gives me the opportunity to share an experience I lived while I was still in Cameroon. Towards the years 1995, I was member of the Comité National d'Épidémiologie, the epidemiological, I don't know how to say it in English, but it was in French, Comité National d'Épidémiologie. And I had the opportunity to conduct a research on the health financing in Cameroon. We were less than over some years, I think it was from 1960 to 1990, something like that. The budget has never reached 5%, and I was blamed for raising this. But I say I was young, and I said no, I will say it, and I said it clearly that we have never reached the 5%. So, so another view or another way of seeing this is that the bar with the head of states were wise enough to put the bar high so that every year we make effort to reach it. We may not reach it. 50% is a lot. if we have only 10 ministries and we have to share equally the budget among the ministries, it will mean that every ministry will have an average 10%, which will not be the case. And we know that we have so many ministries and we have also so many agencies, Boko Haram or so on, that I think we can understand it, that from time to time, the governments do not give priority to the healthcare because there are some other pressing issues. With that, ladies and gentlemen, I would have loved to give a floor to the audience to ask some few questions. I would have loved also to ask to raise other many points that I had prepared, but we have to respect the constraint, the time constraint. Otherwise, as I said it, Vanessa will blame me. So take away for this issue. I will not go back to what you've said already. I will just mention that healthcare financing in Africa is an important issue, and we should pay attention to it. Money may be there, but what we need is the good capacity to mobilize money. Health financing should not come only from outside. It should also come from inside. And that's where we have to put emphasis on domestic resource mobilization. So if I was to retain only one point, I would say domestic resource mobilization is extremely important for us in Africa, whether it applies to healthcare, whether it applies to education or every other things. We should put more emphasis on building capacity for domestic resource mobilization. I know that if ACBM was listening to me, they will be very happy. In that, I thank you very much for taking part in this important session. On behalf of the Nkafu Policy Institute, I would like to thank you all, not only the panelists, but also the audience, and apologies for not having enough time to giving you the floor to bring your own and highlight in this important issue. Thank you so much.